Welcome to Radiology Made Easy. Today, we'll be discussing an interesting case involving a frontal chest radiograph of a skeletally mature female. Several abnormalities are evident. Although the radiograph is fairly well centered, the right hemithorax is more lucent than the left. The right lung is of greater volume with coarse interstitial shadowing and the impression of cystic change involving all zones. There is subcutaneous emphysema, most conspicuous lateral to the left upper ribs. A linear opacity running between and parallel to the right third and fourth ribs posteriorly could represent the lung edge with a small apical pneumothorax. A line of gas running parallel to the left side of the mediastinum could feasibly represent pneumomediastinum, although appearances are inconclusive, and there are no ancillary signs such as the continuous diaphragm sign. No left-sided pneumothorax is identified. There is pleural reaction at both costophrenic angles. The left hemidiaphragm and left heart border are clearly visualized, and increased density in the left mid and lower zones is more in keeping with effusion than collapse or consolidation. One explanation for the marked discrepancy in the appearances in the lungs is that there has been a lung transplant on the left. Differentials for the underlying lung disease include lymphangioliomyomatosis, LAM, tuberous sclerosis, TS, neurofibromatosis, and Langerhans cell histiocytosis, LCH, the latter two being less likely given that cystic change is evident at the right base. It would be useful to review any available previous imaging to assess for change, but if the assumption that there has been a left lung transplant is correct, and the surgical emphysema and pneumothorax are new findings, this case should be discussed urgently with the referring clinician. So, our diagnosis is LAM with left lung transplant and pneumomediastinum secondary to bronchial dehiscence. When evaluating cystic lung disease, consider the zonal distribution of the disease. LCH tends to spare the lower zones, whereas neurofibromatosis is predominantly apical. In contrast, LM and TS have no zonal predominance. Consider the size and shape of cysts. LCH nodules evolve into thick and then thin-walled cysts of varied size and shape, characteristically bizarre, whereas the cysts in LM and TS are more uniform. Ancillary findings may provide clues that aid diagnosis. The fact that a patient is male effectively excludes LAM as a diagnosis. LAM or TS should be suspected if there are renal cysts or angiomyolipomas, and LCH and neurofibromatosis may be associated with bony abnormalities. LM is rare in real life, with a prevalence of around 1 in a million, but it is not an uncommon case in examinations. It affects only females, typically those of childbearing age. Abnormal smooth muscle proliferation in the walls of small airways results in post-obstructive cyst formation throughout the lungs, the cysts being randomly distributed with normal intervening lung. These cysts typically exhibit more uniformity of size than the irregular cysts seen in LCH. TS and LM involve, in essence, the same pathological process, hence exhibit identical features on thoracic imaging. Pneumothorax is a common presentation, and chylothorax is also commonly seen. Chylothorax can be differentiated from a simple effusion on CT scanning by its fatty attenuation. Lung transplant may be considered for end-stage LAM, although recurrence in the transplanted lung has been reported. That's all for today's case. If you found this video helpful, please like, share, and subscribe to Radiology Made Easy. Thank you for watching.